I'm Brian Mishara, and I'm pleased to be with you virtually today. I'm coming to you from the University of Quebec in Montreal, which is an urban, rather large French-speaking university in downtown Montreal, Quebec, Canada. I have a few disclosures. I've spent most of my life working in suicide prevention. When I was quite young, I had a marvelous opportunity to visit Cecily Saunders at St. Christopher's Hospice, and I was really very much impressed by the potential to die with dignity and compassion. And I became a convinced believer in the benefits of palliative care. I believe, and I have empirical evidence and experiences, that suicide prevention can prevent premature deaths and suicide attempts. And afterwards, people can generally be happy and thankful to be alive. It doesn't always prevent suicides, but you do save lives. I believe everyone has the right to kill themselves. It is a personal choice. However, anytime I come across someone who wants to die, I will do my best to explore every option possible to increase hope and decrease suffering, regardless of the reasons given or what appears to be a very hopeless situation. So I have a bit of a myopic view because most of my life experiences would have been with suicidal people in situations that they felt were completely hopeless. And more often than not, they are able to find hope, or we help build hope and alleviate their suffering. So we're talking about suicide, which is an intentional action by a person to end his or her life. In Canada, we use the term MAiD, medical assistance in dying, to cover two things: euthanasia and assisted suicide. This was a brilliant political move because it found that people are willing to vote in favor of and be supportive of medical assistance in dying when a physician ends someone's life by euthanasia. If you use that term, but they don't like the idea of being euthanized by someone. That's so euthanasia, when MAiD is practiced as euthanasia, it's an intentional action to end a person's life by another at the request of the person for compassionate reasons. And the other action to prematurely end one's life is assisted suicide, in which the assistance involves providing the means for a person to end his or her life at the request of the person for compassionate reasons. And it's a suicide because the person uses the means provided to end her or his life. And for example, in the United States and in Switzerland, only the practice of assisted suicide has been legalized, whereas both practices have been legalized in other countries, including the Netherlands, Belgium, and Canada, though in Canada, assisted suicide is almost never practiced. So the intention in both is to end life intentionally to alleviate suffering. The suffering in the case of suicide is at this moment the person is suffering. In the case of MAiD, it may be to prevent anticipated suffering down the line sometime, or to ensure a death with dignity, or to end or prevent an undignified life experience that one is either experiencing right now or anticipates experiencing in the future. I have written with my colleague, the law and ethics professor David Weisstubb, a number of articles in which we propose that the ethical premises that we have, our moral, ethical beliefs, have practical implications to what one will do to help another person who is considering ending their life. And we have summarized a few thousand years of philosophy and some simple categories, which are actually much more complex than I can present in a few minutes. But basically, we have contrasted people who hold what we call a moralist stand, that have a moral belief in the preservation of human life. This can be based on religion, that one's life is not her or his to take, or that this is something that is condemned, strictly condemned, for example, in the Muslim religion. And on the other extreme, you have positions such as some years ago taken by the psychiatrist Thomas Szasz, certainly by existential philosophers, which one can characterize as a libertarian view, that suicide is a choice that humans have. If you're an existentialist, you might believe that this is the ultimate choice that we have, to continue to live or to end our lives, and one should not interfere with that important ultimate choice, which we are capable of taking. And most people fall into a category and believe in between, which are relativists who believe that it depends on something. There are situations where a premature death by suicide or medical assistance in dying may be acceptable, and there are conditions when it is not acceptable. And there are different categories of relativists. Some believe it depends on the context. So, if I'm going to be dying in the next 48 hours from horrible progressive cancer, and I am suffering physically and mentally, and you might feel it is correct to do something to end my life a bit earlier. Or in certain circumstances, for example, someone who is being tortured and will be eventually killed by the torturers who decide to end their life. So it could be due to the context. Another category of relativists are consequentialists, who believe that the consequences are important and may justify different human behaviors. And of course, consequentialists have had a lot of criticism for various reasons, but those arguments are still given to justify various actions. And in one of our analyses, which is published, we contrasted the position of United States suicide prevention helplines with the position of Samaritans in the United Kingdom, where the Samaritans have a policy, and this is being modified a little bit in practice, but basically that the decision to live or die rests with the caller to Samaritans, and that they will do everything possible for someone whose life is in danger, for example, someone who is on the verge of attempting suicide, to accept help, or even someone who has started a suicide attempt, but they would not compromise the confidentiality of the interaction and trace the call and send the police and an ambulance from stopping from someone from going head to head with an attempt, for example. And they justify this for moral reasons, that they have a belief that, people, this is a personal decision, but they also have a number of consequentialist arguments. They say if people learn that we might trace the calls and send the police and ambulance, people will not call for help. They'll be reluctant to call for help. They're basically successful in convincing a person whose life is in danger to say where they are and accept help. It's very rare that they don't do that, but this is their position. This contrasts with U.S. helplines, which have a very aggressive interventionist approach. So even if a person is not attempted suicide, an attempt is not going to happen today, but it's going to maybe tomorrow, within the next 24 hours. They will trace the call, they'll send the police, they'll break down the door, they'll usually take the person to an emergency room. And they have a moralist position that this is that you have to protect human lives, and forcefully, whether the person wants that help or not. They also have a consequentialist argument they cite, saying that people generally thank them for it when they do this. And unfortunately, the United States is the only country in the world where firearms are the #1 method of suicide. So often the person has a gun. So the police who is sent to the home know that this is a person with a gun and maybe has mental health problems. So they take out their gun when they get to the door, and often have to break down the door. And when they see the person sitting there, if the person's holding a gun, they might shout to put the gun down. If the person hesitates, they might shoot. So every week or two, there's some people in the US where the helpline has sent police to help them, and with an ambulance workers, and the police wind up killing the suicidal person. So we think that it's important to try to unpack and understand one's ethical premises. So why do people want to die by suicide? The answer to that really can be summarized by the fact that people kill themselves to stop suffering they think is interminable, is never going to end, unavoidable, there's nothing I can do about it, and insupportable. I just cannot go on living with this much suffering. And the key word in that sentence is the word think. So the 16-year-old who thinks that whose girlfriend just left him and is suffering incredibly from this and feels that there's nothing he can do. She's never going to come back. This is the love of my life. And I cannot go on suffering like this. I'm going to suffer like this forever. Can go ahead and attempt suicide or die by suicide. And even though we might look at that person and say, this is ridiculous. You're 16, you'll fall in love again. This is, but if the person feels that way at the moment, then the individual can go ahead and proceed with suicide. It's pretty much the same for MAiD, except that the suffering may not be intense at the moment. It may be anticipated suffering in order to avoid dying in a manner which we think is going to occur, or the suffering is real at the moment, but what I'm anguishing about is what's going to happen in the future. So an example of this might be people with amyotrophic lateral sclerosis, Lou Gehrig's disease, a debilitating, progressive, incurable illness. In the Netherlands, when they're asked why they request euthanasia or assisted suicide, and not a large proportion do, a fairly small proportion will make that request. The majority say that it's because they're afraid of eventually dying by asphyxiation. And the reality, of course, the reality is that 2 or 3% of people with that illness will die by asphyxiation, and doctors claim that this is preventable. So in this instance, people ask to have their lives ended prematurely because of their anticipation of something, and sometimes what we anticipate is going to happen, and sometimes we're not very good at predicting what's going to happen in the future. However, with MAiD, the reasons people give are rarely or less frequently physical suffering. They usually give reasons like loss of autonomy, wanting to die in what they believe is a dignified manner, inability to engage in enjoyable activities, loss of control at the moment, actual or anticipated. So for example, here's a table of the reasons given for assisted suicide in Oregon and some changes. Number one was just less able to engage in activities making life enjoyable. Obviously, these are not mutually exclusive. People can give multiple reasons, but loss of autonomy, loss of dignity, loss of control of bodily functions, either current or anticipated, feeling of being a burden on family, friends, and caregivers. And pain control is just about 25, 30%. And in some rare instances, because they do not have universal health care in the United States, financial implications of the treatment cost too much to keep me alive. This is one example. There are many studies. I just wanted to note that we often confuse having an irremediable illness or situation with having suffering, which is irremediable. Because the reasons people give for ending their life are not because I have cancer or I have a degenerative disease that is incurable, but the reasons they give are various consequences which results in suffering. And some of those consequences may be changed. Situations may be dramatically improved, even though the illness itself is incurable. One of the prime characteristics of suicide is ambivalence. One of the great pioneers in suicidology research, Edwin Schneidman, psychiatrist from Los Angeles who wrote many of the classic books, felt that all people, all humans have a certain level of suicide risk at any moment. It's not zero. It may be extremely low and even imperceptible at the moment, but things could change and increase that risk. So, if you are captured by someone and tortured, you may increase, that risk may increase. Or if things happen to you, you are suddenly in a car accident and you are paralyzed from the neck down, you may feel suicidal, though the research shows that people with disabilities, even serious disabilities, even though suicide risk may increase dramatically immediately after they have those disabilities, in the case where it's not congenital, basically have lower suicide rates than people who have no handicaps or disabilities. But suicide risk fluctuates, and the idea is that even people who go ahead and initiate a suicide attempt are not 100% convinced that that's the right thing to do. We have a certain will to live. There's some animal instincts, but also it's a way of dealing with the situation, and we can conceive of other ways. We have other fantasies. You don't have to be completely convinced. You have to just think it's the best option at this moment. And in suicide prevention, what we basically do is increase that part of the person and that ability of the person which is expressing some hesitation or ambivalence. We can increase hope even in situations which the person feels is completely hopeless, and we can treat some underlying problems which increase the vulnerability of the person to attempt suicide, such as depression and other mental illnesses. In the Netherlands, one of the requirements for access to MAiD is that you must, the physician and the patient must both be convinced that there are no other treatment options to alleviate the suffering before offering death as a manner to alleviate the suffering. And even though the Netherlands is considered extremely liberal when it comes to the application of euthanasia and assisted suicide, for over 40% of requests are denied, very often because the doctor thinks there's another treatment option. And usually the patient, when offered that treatment option, tries it and doesn't come back with a request for euthanasia. It doesn't mean there's a treatment for the underlying illness, but for whatever it is, this concern about dying alone or feeling being in a dignified situation, or feeling depressed as a side effect of some of the treatments they're receiving for their illness, such as some of the effects of chemotherapy involve the development of clinical depression. No one is forced to try those options, but the idea is that the state does not have an obligation to provide death if other options are available. Now, it's very curious what's happening in the United States. So in the US states, there's about a dozen United States which have legalized assisted suicide. Most of the people who request this are suffering from advanced states of cancer, and they the people for whom this is granted have convinced two physicians that they are suffering intolerably at this moment, and the only way to end this suffering is for them to end their life. They're prescribed a lethal medication, which they obtain, and in the state of Oregon, which is the state which first legalized assisted suicide, we have the most data on it. To date, 36% of the people who obtained that medication and convinced the doctors they absolutely had to die never took the medication. They just sort of put it aside in case it got really bad, and it never really did get really bad. For me, this suggests that the idea that somehow in suicide there's ambivalence, but when a person has a physical illness and wants MAiD, euthanasia or assisted suicide to end their suffering. There's never any ambivalence. It's a yes or no decision. Well, the data from Oregon indicates that this is clearly not the case, as well as some of the experiences, for example, in the Netherlands. Now, in high-income countries like all of Europe, Australia, United States, New Zealand, over 90% of people who die by suicide have a diagnosable mental disorder. Not all have been diagnosed, but usually they have. But if you look back and do a psychological autopsy study, you find that they have all the symptoms. And a mental disorder compromises one's ability to make good decisions. If you're depressed, no matter how well things seem to be going, you feel hopeless. If you have psychosis, where you have hallucinations, where you hear voices, you may hear voices encouraging you to end your life, or you could be paranoid, feel people are out to get you, and you have no escape. So the symptoms of mental illnesses diminish one's ability to make the right choices. It's not on the slide, but in many countries, including in the UK, a very large proportion, up to 50% or more of people who die by suicide have alcohol in their blood at the time of their death. And sometimes that's very high quantities of alcohol. And we know that when we are under the influence of alcohol or other drugs, it's not a good time to make a decision that we may not regret sometime afterwards. So mental illness is the highest risk factor in terms, it's not the cause of a suicide, it's just something that increases the risk because of its influence on one's ability to make decisions. Now, in Canada, we're in the process of expanding access to medical assistance in dying to people who are only suffering from a mental disorder. This is a heated debate with a big lobby saying that we're denying a medical treatment to people who suffering is just as real as the suffering of people who have a physical illness. And I don't deny that suffering from mental illness can be just as bad or worse in many instances. But I believe there are some strong issues for this expansion. In the case of MAiD, one has to also consider that there are iatrogenic impacts of treatments on mental health. So if you look at the treatments people receive and are receiving for mostly medications, but also some other treatments, the side effects often include the development of things like depression or anxiety. And there are also other impacts of physical illness, such as actual isolation. People are less likely to touch someone who has cancer. There's research on it. But there's some hesitation to touch someone. It's as if it could be contagious. So there are changes in one's life experience, and there is a high prevalence of psychiatric illness among people who also have physical illnesses, particularly chronic physical illnesses. Now, as previously mentioned, some suicides are impulsive. Most suicides are not completely planned in detail, but there is tremendous amount of consideration of methods, and more frequently, people are going on the internet to see what would constitute a method which would be acceptable for me. Some of these impulsive suicides occur under the influence of alcohol or drugs, or in extreme crisis situations that don't last, like the moment your wife's says, "I'm leaving you, I'm in love with your best friend. This has been going on for years, and I'm taking the children and the cat," and walks out the door. That might be a particularly vulnerable moment where someone could do something impulsive. In the crisis situation, which a day or two later, things may not be quite like that. In the case of murder suicides, people who kill someone who they know, and a lot of homicides involve friends and relatives. One feels terrible afterwards and impulsively will attempt suicide, for example. And these lack the planning which is involved in medical assistance in dying. One may argue that when someone has a terminal illness, they're going to die anyway. MAiD involves changing the timing and manner of death, but doesn't actually determine whether or not the person's going to die. They're going to die anyway, but they will die earlier and in a different manner. And that somehow this can be considered to be ethically different from ending the life of a person who is not near death. So someone who has a degenerative illness, but actual death is a long ways off, or someone who is physically healthy, who is suffering from a mental illness. Now, most suicides are prevented. Most people who seriously consider ending their life will never attempt suicide. So if you look at the statistics per 100,000 population per year, and you ask the question in the past year, have you seriously considered killing yourself? You have to add the word seriously. If you don't add the word seriously, you find that most human beings on Earth have thought about suicide sometime. And if you don't remember having thought about suicide, think back about your adolescent years, your teenage years. But now we can think about anything. You know, I can think of standing up and walking out the door and, going out and enjoying the beautiful day here instead of giving this talk. But that's a thought that passes in my mind, or quitting my job and moving to the South Seas Island. We can think about anything, but seriously thinking about something is a little bit more likely that one might do it. And up to 300 per 100,000, this is a fairly large amount, say they attempted suicide. Not that many show up in emergency rooms and hospitals with a suicide attempt. But if you ask, have you attempted suicide in the last year? That's basically what you get. So very few of the people who seriously consider say they did something to attempt suicide. Most of the attempts are, well, I was standing on the balcony and I was thinking of jumping, but I didn't jump, or I took some pills, but I woke up the next morning, I was okay, and I didn't take that many, something like that. But a small percentage of them worldwide, it's now about 10.5 per 100,000 will die by suicide. So even people who attempt suicide, most people stop those attempts before they have a lethal outcome. They stop the cutting, they try to vomit their meds, they get medical help. And so very few die. The reason so few die isn't that humans are hopelessly incapable of killing themselves, and it's because people, even those who go ahead and initiate attempt, tend to get help and stop the attempt. So most suicides are prevented by people themselves, and suicide prevention activities, are effective. People who are hospitalized for a suicide attempt, the 10% will attempt again in the next year. You can lower that by having some proactive follow-up, but it's a very high risk factor. You want to find people at high risk of suicide, look at people who've already attempted, because people who have attempted are capable of attempting. Not everyone is capable of attempting, and their life situations don't necessarily change just because they've been in the hospital. They come back into the same problems they've got to deal with. But the upside of this is that 90% will not attempt. And it's true that 1.3% of people who attempt suicide will die by suicide, but it's a very small percentage. So this suggests it's worthwhile helping people. And the helpline callers find now we have follow-up data. People say that they've gotten help, that they were going to kill themselves and it didn't. And when calls are traced and ambulances sent and people are sent to hospital against their will, most of them will call back and say, thank you, you saved my life. Now, some will not. Some will be furious that they're still alive, and they'll go out and attempt again and will die by suicide. One of the questions is, how many lives do you need to save to justify doing things? For some people, saving one life is enough to justify an action. And I'll talk a little bit later about experiences with people in hopeless situations. I guess I can talk about it now. I don't remember if I have a slide on it, but one of the things that I am involved doing is training in different countries, usually places that don't have much or sometimes not anything going on in suicide prevention. And I've helped start some helplines in places like Lebanon and Uganda. But one of the things I did a bit of is training people who work with refugees in refugee camps. And when I do these workshops, invariably, every single time I start out, people come in, they've got half a day or 2 days with me to learn about how to help with suicide prevention. And within the first 2 or 3 minutes, sometimes even before I can say anything, someone raises their hand and very politely interrupts me and or says, listen, I have an important question. And basically it's always the same thing. I know this man and he wants to kill himself. He's been in this camp for 10 years. He's from Somalia. He's in Tanzania now in this camp. And he used to have a business and a family and a home and a life. Now he's just living on what's given to him here in his little hut. And he witnessed his whole family tortured to death. People around him don't speak his language. If I was in that situation, I'd want to die. How can you talk about suicide prevention for someone like that? And the answer to that is that this is a very strong person who has a lot of capacity to deal with horrendous problems because he's still alive. Something has been keeping this person alive for those 10 years in the refugee camp. Something has permitted him to survive all those horrendous experiences. Suicide prevention involves identifying what has been keeping him alive and focusing on that and building on it. So you don't talk to someone like that, asking him to tell all the problems he has. That's just going to make things worse. You focus on, this week, when was it that things weren't quite so bad? Or even you had forgotten about your worries. If the person says, well, I'm always troubled. There's no time like that. And when was it maybe not quite as bad? That I make tea in the morning. I have a sip of the tea. I think about my life when I used to have a life, but I don't anymore. They're all gone. Tell me about, how do you make your tea? What do you do? And you got to focus and build upon that. Well, this is another topic, but I wanted to give you a flavor for it. People often say that a request for MAiD is more rational. And people talk about rational suicide. I believe that when we say the decision to end that person's life is rational, what we really mean is not that there's some reasoning going on, that it's understandable to me. I think that if I was in that situation, I would feel horrible and want to end my life. It makes sense to me. It doesn't mean that some rational process or reasoned decision-making occurred. As I mentioned, reasoned decision-making is compromised by mental illness, substance abuse, crisis situations. In the case of MAiD, you need to have acute physical suffering. Acute physical suffering doesn't increase one's ability to be rational. It's all we want is the suffering to end. We have fears of the future and side effects I mentioned. So, I don't think you want to look for rationality in those situations. But more important, I contend that the most important human decisions are not rational. What's the most important decision you made in your life? Who you marry, what career or vocation you have in life, even decisions like what car we buy. We don't go out and buy the most economical, non-polluting, reliable car. People buy that fancy sports car or that SUV that I like, and we pay extra to have it in a certain color. If the major decisions in life are not rational, why would you expect when someone is terminally ill or has a horrendous disease that suddenly they become more rational? So this is an irrealistic belief that somehow there's some more rationality being involved. As previously mentioned, previous speaker, we live at a time where there is a tremendous emphasis on individual freedom. We're not at a time where people are talking about moral responsibilities or communal responsibilities by and large. And we are allowed to make poor choices. We can still smoke cigarettes. It may be difficult to find a place to do it, but we can. We can engage in risky sports. We can go climb a mountain without good training. We can make horrible environmental choices, which will compromise the life of the planet. We cannot recycle and pollute more to a certain extent. So we have the right to make a lot of poor individual choices. When we influence others by our choices, that's another situation. However, sometimes society steps in. Okay, I'm going to script this. I was going to tell you about the legend of Pandora in the jar. It's an interesting legend. Basically, Pandora was sent down to Earth with a jar. She was told not to open. It wasn't a box. It was changed to a box later, and Pandora was told never to open it. She opened it, and all the horrible things like sorrow and disease and madness and old age and death that didn't exist on Earth came out to plague humanity forever. But Prometheus added to the box hope to help people survive all those things. That's for me. That's an interesting legend, and I talked a little bit about fostering hope. These are my conclusions, and I'll end. Respect for autonomy doesn't preclude active interventions to prevent suicide and ending one's life by MAiD, even if you respect the decision rests with the client. I don't believe that suicide prevention services use any form of illness, disability, eligibility for MAiD, terminal diagnosis to discriminate and not provide suicide prevention interventions. I don't think MAiD should be offered to people with a mental illness as a sole reason, simply because, and there's a lot of research on this, it is impossible to predict irremediability with mental illness. It doesn't follow a predictable course, and research is very clear that we just can't make those decisions, and a lot of people will needlessly die if one tries to make those predictions. And that was my conclusion. I'll stop here. I do have a number of publications you can look at some point.